The recording will be posted on the Commission's webpage shortly after the meeting. TBW may also be streaming this meeting live and archiving it for additional viewing opportunities. For everyone's reference, today's agenda can be found under the first tab in the materials. And Vicki Lowe, Chair of the Universal Healthcare Commission, will now call the meeting to order.
Thank you, Mandy. Welcome, Commission members. It is 2:06 and I'm calling the December 14th, 2023 meeting of the Universal Healthcare Commission to order. I would like to start with a land acknowledgement and we do land acknowledgements to remind people of the importance of the land that we all live in and that the advantages of ownership of land have for people. Where I live, I have a privilege of being able to reside on the land of my ancestors, which is here in the Statithlam Nuskalayam territory, the Jamestown Slalom. And I'd just like to honor my ancestors and invite you all to know and understand whose land that you live on and just honor them for their stewardship of our land since time immemorial. And then a warm welcome to all of our commission members. You can go ahead and turn your cameras on. I think it's just in the room at the Healthcare Authority. They're having camera issues. And just like to welcome you. This is our 15th meeting, which seems a little crazy, but happy to see you guys here. First, I want to make sure that Megan is here. We have a new member, Megan Matthews, who is joining us on behalf of the, there she is, the Office of Equity. Megan is the director of the Office of Equity, and she earned her master's degree in public administration from Evergreen State College. She is certified as a change management practitioner, a diversity professional, and a diversity executive. Megan also co-taught a master's program at Evergreen State College, emphasizing democratic governance and social change for current and future public administration. She is passionate about social justice and ensures fairness for everyone. We're excited to have her join the commission. Hi, Megan. Do you want to say hi? Oh, looks like you're in your car. Okay, well, maybe when we get to roll call, you'll be able to unmute. All right. I also want to mention that the Healthcare Authority was invited to present at the Senate Health and Long-Term Care Committee meeting. That was last week or the week before. So Pam McEwen, Mandy Weeks, and myself presented and gave a look back on the work of the commission and then a look forward for upcoming work. A large number of stakeholders attended and we want to thank them for being there. It's nice to meet some of you in person after all of the input we have gotten from you. And our presentation was well received by the committee members. Megan, did you figure it out?
Yes, sorry about that.
It's okay.
I'm like, once I get to a screen, I'm like, I don't know what I'm doing. Good afternoon, everyone. My name is Megan Matthews. My pronouns are she and her, and I'm the director for the Office of Equity. It's a pleasure to join you all. I attended last month's meeting for a little bit, and I just left the healthcare disparities meeting early this morning. So it's lovely to kind of center this day on health justice in Washington State. And I look forward to participating and collaborating here as well.
Thank you, Megan. It's so great to have you join us. I'm going to give an overview of the agenda. So, and then when we get to roll call this month, since we don't get to be the, privilege of being in person, we've been doing these getting to know you questions. Today's question will be, what is your favorite holiday tradition and what the holiday is that you celebrate, if you want to think about that. So after roll call, we'll vote on and approve the October meeting summary. We'll take public comments. After public comments, we get to hear from Pam McEwen from the Financial Technical Advisory Committee. And then we'll continue our discussion on transitional solutions. I hope you guys had those transitional solutions because we plan on taking some votes on what we're looking at for 2024 planning. And then after that, we've set aside some time to hear from hca regarding their eligibility determination. We're trying to like parallel our work with what they have in their bill. And then finally, we get to hear from Commissioner Jane Beyer regarding the Office of the Insurance Commissioner's affordability report. I think that'll be really important. You know, we voted to extend our meetings from ending at 4 o'clock to 5 o'clock starting next year. So today, technically, we end at 4, but I'm hoping if you don't get to hear all of Jane's report, that we can take a few extra minutes to hang on and have some discussion too. I know it's tight, so hopefully we'll get it all in. But I just want to encourage each of you to participate and give input. And if I don't hear from you, I think you know I'm going to call on you or call you out. So I really appreciate you guys for all the time that you've put into this. So just thank you for being here, and I'll pass it back to Mandy to do roll call. How are you guys doing there in the room, Mandy?
We're doing all right. I'm sorry we're not on screen, everyone. We're still working on it behind the scenes. I will call on commission members by their first name in the order listed in the agenda, which is in alphabetical order by first name. When I call on you, please unmute your microphone and let us know you are here and what is your favorite holiday tradition. Then please mute your microphone again. Chair Vicky?
I am here. And my favorite holiday tradition is making butter cookies and frosting them. It used to be with my sisters, and then it was with my kids, and now I do it with my grandkids. And we have a lot of fun doing that.
Thank you. Senator Ann? Senator Ann? Fidesha? Fidesha? Dave?
Dave Eisminger here from the Healthcare Authority. My favorite holiday tradition is taking a rest before legislative session starts. But in all seriousness, it's putting up a tree and figuring out and having my cat watch how cute different ornaments are and which one he's going to try and take off the tree, and that I have to keep putting back on the tree.
Thank you, Dave. Senator Emily? Senator Emily? Oh,
Hi
sorry.
there. I'm Emily Randall, state senator from the 26th legislative district. And I think my favorite holiday tradition is also food related. We make tamales in my family, and this is my first year making them without my grandparents. So I'm looking forward to honoring their memory in that way.
I love a good tamale. Estelle? Estelle? Jane?
Hi, everyone. I want to apologize for being off camera. We're in a car. We just flew in from a trip to the East Coast, which leads to my favorite tradition because this year we got to light the menorah together with family.
Thank you, Jane. Joan?
Hi all. I'm not sure if you can see me.
Thank you.
Oh, great. Hi. Let's see. Joan Altman, Director of Government Affairs, Strategic Partnerships at the Exchange. I love a good brunch moment. So like day of family holiday brunch, but I also I always go ice skating every year with my younger sister, which is an adventure in falling down and trying not to get hurt that has only become more interesting as we have gotten older. But anyway, yeah, happy holidays all.
Are you making the brunch?
No, absolutely not. I am bringing the champagne.
Excellent. Representative Joe?
Joe Schmick, 9th District. I enjoy eating all the special things that people make during the holidays to celebrate this time of year. And I would say that's my favorite thing.
Excellent. Lots of cookies stacked up? I know I do. Kristen?
Good afternoon, Kristen Peterson with the Department of Health. The holidays are the one time a year that I make fondue. So probably a good thing, big bowl of cheese and bread, but it's a good holiday tradition for us.
Nice. Representative Marcus?
Hello, all. Honestly, one of my favorite things is the station that runs Christmas Story like 24/7, and I just watch pieces 10 minutes and 15 minutes at a time continuously. And the other one, not to try and one up Joan, but I love that feeling when I've hung my lights and I'm still intact, because every year it gets sketchier and sketchier. But yeah, I don't enjoy that. So surviving that is a good tradition.
So lots of emergency room visits on the 26th or the 25th, I hear. Megan?
Good afternoon again, everyone. Megan Matthews here. I'm gonna have to go with Representative Joe. I like everything you can ingest. Specifically, we do a Christmas bread competition. I love that. Hot cocoa, and I like to try new drink mixtures.
That sounds yummy. Mohammed?
Good afternoon, everyone. I actually haven't thought about that question before today. We travel a lot, but we tend to do something different every year. And since we don't celebrate the Christmas, it's hard to keep track of which ones we like the most. But I love watching neighbors' lights and seeing friends celebrate Christmas.
Oh, and it could be any holiday tradition. It doesn't have to be.
Yeah, well, the Muslim holidays like the Eid is not as fun as the memories that I have as a child back home. So it's not, I'm not very grumpy, but I don't seem to enjoy a lot of stuff.
That's all right. Nicole, thank you for sharing. Nicole?
Hey there. Oh gosh, let me see. I think one of my favorite traditions is we usually go to our chosen family's house on Christmas Eve. And so we have a good time with our friends there. And then we spend Christmas Day with our actual families. So it's a lot of fun. And I also enjoy eating things that other people make, because that's how it should be.
I agree. That sounds like the right way to do it. And it sounds like maybe, and Stella? Stella? Sounds like maybe we should do a recipe swap. If anybody has any favorite holiday recipes that they'd want to share, I'm happy to send those out to commission members. I know we had a lot of food talk just now. So thank you, everyone. And I will turn it back to Chair Vicki Lowe, who will facilitate review of the meeting summary and public comments.
Thank you, Mandy. Thanks everyone for sharing. So please join me in turning to the second tab or checking out the screen on your commission book. The recording of last meeting in October is on the webpage, and we'll vote on approval of the October meeting summary. Is there any discussion on the summary or proposed changes before we do that? And if there's not, I will take a motion to accept the minutes.
I move that we accept the minutes from the October meeting.
Thank you, Representative Schmick. Is there a second?
I'll second. Dave Eisminger.
Thank you, Dave. All those in favor? Aye.
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 Aye. Aye.
Any opposed? All right, motion approved. Next, we'll turn to public comments. So the public comments that we've received since our last meeting are found under tab number 3 in your commission book. We have individuals sign up to provide public comment before the meeting, and we'll start with those who have signed up first. If you have not signed up and would like to make public comment, please raise your hand. Then Mandy will call on you after we hear from the individuals who have signed up. When you are called on, please state your name and affiliation if you have any before speaking. Please do not raise your hand more than once. This will help ensure that everyone has a chance to speak. And you are welcome to provide comments in writing via email at any time. We have a very large number of people signed up for public comments today, so to ensure that everyone has an opportunity to speak, there is a limit of 90 seconds or 1 minute and 30 seconds, as you see on the clock, per person, which may need to be reduced if we get closer to the time limit for public comments. And there's a number who have not gotten to speak but still wish to. We do have a packed agenda today. You see the timer on the screen, and that will be the reminder of the limit. If the timer stops, please stop your public comments. We encourage public comments to be focused on the materials and topics that we are discussing today. We may run out of time for public comments, and if we do, you're welcome to submit in writing. Mandy, could you please start with the names of the individuals who have signed up to provide comments?
Yes, thank you, Vicki. Carrie Simpson.
Yes. Is that it? I'm on?
Yes.
Oh, okay. So yes, thank you for the opportunity to testify. I live in the 32nd Legislative District. My name is Carrie Simpson. I'm self-employed with a women-owned business called Urban Systems Design LLC, a certified WIMBY business in Washington State. I've been in business for myself since 2009, paying city, state, federal taxes as an S-Corp. I pay myself as my own employee of my business, and I purchase my own health and dental insurance through Washington Health Plan Finder. So coming out of the pandemic, I paid about $2,300 total in annual healthcare premiums for 2022-2023 because I was able to receive tax credits based on income, but I no longer qualify for those because I raised my salary this year to a more livable wage. So in 2024, I'll be paying over $6,000 annually for healthcare and dental premiums for a bronze plan that has a high deductible. I'm paying nearly 9% of my income on healthcare for myself. This presents a huge financial burden and risk that puts me in a precarious situation with my income going up and down all year long. And so what we really need is a publicly funded program that breaks the stranglehold of corporatized insurance. We need insurance that goes with you, whether you're employed by someone, unemployed, or self-employed. And yeah, more security for people that are self-employed.
Thank you. Nicholas, I'm sorry, Nicholas, I'm gonna try my best. Duchatel de Montrogue.
Good try. Duchatel de Montrouge. It's a long French name. You won't remember the name, but you'll see it's the long name. So thank you for letting me speak. So yeah, my name is Nicolas Duchatel de Montrouge. I live in Kitsap County, specifically in the 23rd Legislative District. I used to live in Woodinville in the 45th before. I'm speaking as myself, although I do help out Whole Washington and other organizations. I'd like to first commend for having this commission, but I'd like to stress the importance of this commission staying focused on the priority. And the reason this commission exists, in my own humble view, is accessibility. As a previous speaker, and I'm sure many people will testify, many people cannot get access to healthcare or not real access to real healthcare. That is because our society is using a delivery mechanism that basically gives 30 to 40% of monies to insurance company. Let me stress that 30 to 40% of every single dollar we spend goes for administration. Most other countries, it's 7 to 10. That's where the money is. And a single payer like Whole Washington would fix that. There might be other solutions, other ideas, and please provide them if you have them. Just remember that every day, every month, every year that we don't fix this, real people are going bankrupt because of health issues. Real people are being sick and die. So a solution implemented sooner, even not perfect, would be essential. So I stress again, please stay focused and deliver a better way for getting everybody health care. And I think you'll see the money is available in the cost by insurance. Thank you very much. Have a nice day and Merry Christmas. Happy holidays to all.
Thank you. Warren George.
I'm here. My name is Warren George. I served on the Oregon Task Force on Universal Health Care. Want to encourage the Washington Commission, of course. My first comment is today you will discuss a number of possible transitional solution plans. Many of these will actually add to cost or reduce access for patients on Medicaid and Medicare by increasing the number of people at lower reimbursement rates. I urge you to keep track of which is which and pursue ideas which lead to simplification and unification, such as single payer type systems. Second comment, I'm excited to hear additional information from Whole Washington. On their slide 11, you will see a discussion about eligibility, including whether to include residents of other states who work in Washington. Oregon Task Force faced this, and we wrestled with it for days. And part of the answer is that it could be really important for Oregon and Washington in particular to cooperate in their implementation plans. Thank you.
Thank you. Mike Benefield.
Hello, I am Mike Benefield, Democratic PCO for LD 23. Thank you for letting me speak today. We have a healthcare crisis in our state that sees thousands suffering needlessly. Major medical debts, bankruptcies, people losing their homes and lives. On the average, one person dies every day in Washington because of the lack of healthcare coverage. So why is the democratically led legislature moving so slowly? We have legislation available in the Washington Health Trust. Shame on all of us for not fixing this horrible system that impacts our friends, families, and especially our children. Thank you.
Thank you. Our next person on the list is Roger Collier.
Unmute and start video. Good afternoon. I'm probably the only person in this meeting who's had actual responsibility for implementing multiple new government healthcare programs for millions of enrollees. Multiple new government healthcare programs for millions of enrollees. Based on that experience, I'm a little puzzled, frankly, that this commission, now in its third year, hasn't made more progress towards its targets, towards its goals. More than a year ago, the commission agreed that its first priority should be to decide which group should be eligible for a universal plan. However, so far, the commission has made no eligibility decisions whatsoever after more than a year, and has missed its key target dates by several months. Obviously, there are some reasons, but I do have a couple of positive suggestions. First, take another look at the Oregon Task Force. Apparently, more productive approach. They've done far more in a lot less time than this commission. And second, please look at my written comments for this meeting. It's in the public comment material, in the hope that at least some of those comments of mine might help the commission accelerate its decision-making process. We don't have a whole lot of time. This is important. I'd like to see the commission acting like it's important. Thank you very much.
Thank you. Christine Patterson.
Hello, can you hear me okay?
Yes.
Okay. Thank you. I reside on the land of the Colville Confederated Tribes in Omak. I'm married to a wonderful man who was diagnosed at the age of 12 with a degenerative disease of the retina. One of the worst days of my life was in the middle of the pandemic, watching a police officer handcuff my husband in the street, putting them in the car to take him to the hospital for an emergency psych eval. He had a wonderful IT job in our rural medical clinic, and because of his ongoing degeneration combined with the craziness of the pandemic, he was not able to keep up providing IT support for the medical staff. Long story short, he had a total breakdown and could no longer work. Between the time his insurance ran out and the time his disability was approved with Social Security was over a year and a half. My income was enough to disqualify him from Medicaid, but not enough to cover the premium under Marketplace. I almost lost my husband because of this gap in care when he needed help the most and couldn't function. He was abandoned by our systems. He realized that the more vulnerable you are, the less help you receive. Thank you so much for listening to me.
Thank you. Chris Curry? Chris, you're breaking up. Are you trying to project your video? And if so, maybe if you turn it off. Chris, you're breaking up. Chris, I'm going to give you a minute to we'll see if we can circle back around to you at the end and see if you're able to resolve any issues internet issues that you might be having. I'll turn now to raised hands. I see Senator Bob Hasagawa.
Hi, I'm Bob Hasagawa, State Senator for the 11th Legislative District, and I just wanted to... Is Mr. Curry still there?
No, he's muted now.
Oh,
sorry. He might have been
well,
flickering in and out for a moment, but you're okay.
thank you. I just want to express my appreciation for the important work that you all are doing. I know that I can't believe that it's been 14 meetings or so that you announced that you've been through already. And I know that it's mostly volunteer work by the citizens that are participating on this commission. So thank you for that. I wanted to make note of the fact on your commission website, you say that the purpose of the commission is to prepare the state for the creation of a healthcare system that provides coverage and access for all Washington residents. A, through a unified financing system, and B, once the federal government approves this new healthcare system. So on that note, I wanted to draw your attention to the Senate Joint Memorial 8006, which actually got off the Senate floor over to the House, went through the Policy Committee, and made it to the House Rules Committee, where it died at sine die for lack of time. So what that joint memorial does is address your second bullet point there to request, well, the joint memorial does one of three things. First off, it asks the federal government to just create a universal healthcare system. But in the unlikely event that's going to happen, the second option is to pass House Resolution, I think it's 3775 by Representative Ro Khanna from California, that gives states the right to create their own universal health care plans. And in the marginal likelihood that they will pass that, the third alternative is just to give us the necessary waivers that we need so that we can implement our own healthcare plan here in Washington State. So I'm the prime sponsor of 5335, which is the basis for the Washington Healthcare Trust bill. And that actually has a mechanism that circumvents the need for waivers, as I think Andre mentioned, that it is patterned after the San Francisco plan. But if the Healthcare Commission chooses some hybrid or chooses a different path, this joint memorial will get the ball rolling at the federal level so that we can then move ahead to implement whatever you decide in your wisdom that you want to move forward. So I hope that you can support this through the next legislative session and get it out of the House. And other than that, I want to just say thank you for the important work you're doing.
Thank you. Sharon Abreu?
Hi, thank you for this opportunity to comment. I am very fortunate to be on Washington Apple Health Community Health Plan. Before I was on this public health plan, I struggled for years with expensive insurance that did not meet my needs, which are very basic needs. And I just want to say, I wish everyone had access to public health care. I think it's very important. I support whole Washington. I've supported single payer health care for the last 20 years. And it's true what people have been saying. People struggle so much with health care. Everyone should have dental care. Why don't we have dental care? It's part of health care. I remember years ago, the day that my dental insurance actually disappeared from my health plan and I had to scramble to try to afford dental care. Friend of mine has multiple sclerosis. When her job disappeared, so did her health insurance. We have to stop situations like that. So I just want to say I advocate for healthcare for everyone. It's more affordable that way, and I hope that we can find our way to it. Thank you very much.
Thank you. And that's everyone that I have for signups and who have raised their hands today. If you've not had an opportunity to speak or you'd like to speak later, or I know that we had some technical difficulties today with any speakers, please feel free to submit your comments in writing, and I will turn it back to Vicki Lowe.
All right, Mandy, thank you to everyone for your public comments. Next, we're going to welcome Pam McEwen, who is our liaison to the Financial Technical Advisory Committee, and she's going to give us an update from their last meeting. Pam?
Yeah, thank you, Vicki. Good afternoon, Chair Lowe and Commission members. Can everyone hear me okay? Great. So today I'm going to report to you on FTAC's November meeting. And I want to note that FTAC's draft summary can be found under tab 4 of your meeting materials. As you know, the Commission directed FTAC to examine pathways to include Medicaid in the universal system. And our November meeting was focused on gathering information on Washington's Medicaid program to better address the Commission's questions. We heard presentations and followed those with discussion. The first was Commission member Joan Altman of the Washington Health Benefit Exchange, and then Melissa Rivera of the Healthcare Authority, who presented on Washington's Medicaid enrollment process. The Commission has previously discussed looking at these existing processes that could be expanded or repurposed for a universal healthcare system. And this presentation helped FTAC understand the capabilities and strengths of the current Medicaid enrollment platform. And we'll be sharing more details about this in upcoming meetings. We then heard from Commission member Roger Gantz, who's a subject matter expert on Washington's Medicaid program. Roger provided an extensive overview of Washington's Medicaid eligibility groups, benefits and services, reimbursement, and delivery systems. From this, FTAC identified several considerations for integration of Medicaid and areas to examine at our next meeting. As you all know, Medicaid is a huge topic, and different than Medicare And ERISA, I think, provides more opportunities to look at consolidation and building towards a universal system because the state has more flexibility and authority when it comes to Medicaid. So, it's going to definitely take us 2 full meetings to get through this. In January, FTAC will take a deeper dive into the options to include Medicaid enrollees in Washington's universal healthcare system and assess the pros and cons of each option. Then we'll develop recommendations to bring back to you. We'll be eager to hear about the Commission's 2024 work plan and FTAC's focus for next year. And we're going to be looking forward to the next discussion, which will be early in 2024 on Medicaid. So thank you. And always happy to answer any questions.
Any questions for Pam and follow-up? Well, Pam, you must have done a really good job.
I think it's just because it's just the tip of the iceberg. Thanks, Vicki.
Right. Yes. Thank you. And there's in January, we'll keep working on Medicaid. So again, thanks, Pam, and thank you for stepping up and doing this, even though you're newly retired. I really appreciate you for taking this on. We're going to go to Liz from HMA and continue our discussion about transitional solutions. So this is where I'm hoping to hear from you guys as we look at these solutions and vote on them for next year.
Great. Thanks so much, Vicki and Pam, and for all the folks offering comment today. Just to clarify, so we're going to talk about the finalizing the 2024 work plan, and as commissioners are well familiar with, the charge is really twofold. It's the long-term design that Senator hca.wa was pointing to, but also looking at some policy options or strategies that could be done to help pave the way before, flipping the switch to a universal system or unified financing system, because I do think it's important to recognize that with the expansion of coverage for undocumented folks that's coming online next year, there is eligibility for almost every person in the state at this point. If it's affordability and equity and access are definitely questions, and quality, and those are, definitely what we're hoping to, address. I think what's the commission is focusing on addressing that in the future, but also looking for what can be done in the short term to try to address some of the need that is right in front of everyone. So really, just when we think about transitional solutions, that's where we want to get your input on what we want to focus on studying next year to put some ideas forward to either through agency action or through legislative direction. So just to kind of remind everybody of where we're at in terms of what we decided on for the work plan at our last meeting. We decided to extend our meetings the commission meetings to 3 hours to allow for more deliberation. And similarly, the FTAC agreed to extend to 2.5 hours for more deliberation as well. If the meetings, the FTAC was a little bit more concerned about the length of meeting, but agreed to keep that on the calendar. And if they didn't need the time, then they would just adjourn earlier. So that's great. And really looking forward to hearing more of what comes out of your all's discussions next year with that extra time. And with that, there's more opportunity to really dig in more to the potential transitional solutions. And the commission at our last meeting honed down the areas that you were interested in focusing or felt that it was most important that you spend your time on next year, including coverage and enrollment, addressing provider issues, and then purchasing. And the reason those areas were selected by the commission was because there was a recognition that the 3 other bullets below here, affordability and cost containment, capacity and infrastructure, and increased subsidies, were actually being addressed in other forums that were provided an opportunity for movement forward, with the understanding that just like today, Commissioner Beyer is going to be reporting on the OIC study on affordability, that there would be regular updates on related information at the commission meeting. So the commissioners were aware and understanding how that related to the work that's in front of you. So that's what we decided last time. Again, other priorities that commissioners agreed were important over the course of the next year were an increased focus on engagement and looking at changes through the lens of health equity. Okay, so why don't we go to the next slide? So we can go to the next slide, it's just transition. So again, just to remind everyone, really the goal today is to try to help organize two things. One, what areas of what order you all would like to tackle diving deeper on some of these topics. And the transitional solutions, again, you see coverage, enrollment, providers, purchasing, and there are a number of ideas within those buckets. So task one is really focused on figuring out what order you'd like to handle these and if there are natural alignments of topics that make sense to tackle at the same time. And the other area that we'll talk about in a little bit is about the role of FTAC with universal system design. And I'll just put that on hold for now. But in terms of transitional solutions topics and the HMA team with HCA has done a little work to try to provide some guidance or input on potential impacts and pluses and minuses of some of these transitional solutions. So if we can go to the next slide, Angela. So hopefully you all have had a chance to look through this. I don't want to go across and read everything, but just wanted to, have a conversation with all of you about, are there natural alignments? Are there topics that can be collapsed? Do you all have a different perspective on the potential impact? Just so that we can look forward to 2024 and sort out where you would like to, at what point you'd like to go more in depth on some of these topics. So, for example, auto enrollment to Medicaid to no premium or lower cost plans in exchange. The impact is that this would allow for more continuous and seamless coverage for people who are no longer eligible for Medicaid. We know that in California and Rhode Island, there's some pilots going on about this policy as the public health emergency is unwinding. We think, our speculation is that the resources are medium and that the impact would be a 2+ out of 3. So that's the sort of lens that we took in trying to sort these through. And I just wanted to get input from our commissioners about, what rises to the top for you, and are there things that need to be combined?
Okay, who wants to start us off?
Well, and again, hopefully you all had a chance to look at this. I know that we've been talking about it over the course of 2023. So maybe this is just old hat at this point. You just want to say, okay, let's just do them in the order there on the page. But we really want to just get I think another way to think about it is, which are the policies or the changes that we think are going to be important in a unified financing, so in a unified system, in a universal system, no matter what. And what would you like to see, move forward sooner rather than later in order to pave the way? Kristen.
Yeah, thanks. Well, I think the sequencing is sort of a hard question when you look at the list here. But, I go back to a conversation we had maybe a few meetings ago around workforce, and, building a system really does require the workforce to support it. And so I see the motivate interest in preventative and primary care. It seems like that may be a little bit more than like low resource required, or maybe for us, but it does seem like a heavy lift, but something that we should start sooner than later to see, optimal outcome, because I think that is a really good goal for us to have. It seems a little bit different than the other solutions, so I don't know that we can necessarily combine it, but I just wanted to call out the importance of that one from my perspective.
Right. And Angela, I'm just realizing that, let's go to the next slide so folks can see both of them, in case people didn't have a chance to look at it. So, okay, that's great. And I think the, you know, this one was interesting, and I think it's really open to commissioners. We heard this in interviews last year, but I think one thought is that it's increasing, it's a workforce issue. And then when you look at the next slide, there's a number of ideas around provider administrative simplification, provider participation. So it could potentially be grouped in that area. But definitely there's also a component about increasing primary care in general and prevention.
Yeah, I like that it's because that's also about retention. So maybe we think about what will help retain providers in the workforce. Thanks.
Mohammed, I think I saw your hand up too.
I did. Yeah, I have the baby, so my question was already asked. Thank you.
Okay, if we're cool with babies here, so if you need to pipe up again, feel free. Okay, Representative Schmick.
Thank you. I picked out my top three, and the three that I thought that needed to be taken a look at was provider administration simplification, network adequacy, and the standardization of claims adjudicating.
Awesome, that's great. And those are things that seem to really combine. Appreciate that. Thank you. Joan.
Thanks, Liz. Yeah, I had a question and a comment. My question was around whether there were any other suggested groupings, like a discussion slide. You all sort of teed up administrative simplification and claims and provider participation. So just interested in thinking around other natural groupings. The comment was in plans. We actually, staff went down to California to talk to them about the pilot they're doing, among other things, relatively recently. And I think from a timing perspective there, getting through the unwind and looking at what happens in these states that are trying some of these things and looking at best practices that we're sort of figuring out or have been figuring out over the course of the unwind would definitely help inform that discussion. So in thinking about that, I think it's an area we're interested in. I think it's an area that would require a good amount of actuarial resource to look at in a comprehensive way. So I think medium makes sense. And then from a timing perspective, I think getting through the unwind and then talking to some of our colleagues in California about, you know, how it worked and lessons learned from having gone through it would make sense from my timing perspective.
Okay, and you were cutting in and out.
So I guess would advocate for getting us through the unwind and chatting.
Okay.
If that's an area that, sorry, I'll get off video and see if that helps.
So I heard you say looking at other states going for doing auto enrollment and getting through the unwind and then looking at it as a potential strategy for, you know, the future, not for right now at this very moment. Uh-oh, we may have lost Joan. Okay. Joan, feel free to chat me or put it in the Q&A or something, because I don't know if there's chat. Jane.
So I apologize if we discussed this at the last meeting, just in terms of capacity.
Mm-hmm.
We're being asked which of these we might want to are we talking about, yes, we would eventually have capacity to do all, it's just a matter of what we do first, or do we have to narrow down?
We already did the narrowing and took 3 huge buckets off.
Right.
And now we're back. These are the areas that remain. And my understanding is that we do have capacity to address all of these. And I think it's a matter of deciding how we want to sequence and consolidate them for, you know, for organizing purposes.
So I agree. I think it was Representative Schmick, right? Standardizing claim adjudication, provider admin, SIMP.
Mhm.
Those, if we do them, I think should be done together,
Okay.
right? Because they're linked to each other. And if we go back to the previous slide, if we can do
Can we go
that.
back, Angela?
Or
There's some technical difficulties.
oh, okay.
Can I share my screen?
Yes.
Okay, I'll take the burden off of you guys. Just a second.
Okay.
It's okay. No, it's technology is sometimes not our friend. So hopefully you all are looking at this slide. Are you looking at it?
Okay. Yep.
Okay,
Yep.
so here is slide 1, and here is
Yep.
slide 2. And then here were our discussion questions, which already grouped those 3 together, but I'll go back to slide 1. So
Okay.
here we are. Yeah.
So in terms of grouping, I think the first 3 would be grouping, because there what you're doing is you're trying to maximize participation in programs that are already in place. And then in terms of, I mean, uncovered ambulance services and services not covered by the BBPA actually go together.
Perfect.
And it'll be even more obvious when we have the discussion in the upcoming session about ground ambulance balance billing. So I would recommend doing those 2 together. And then preventive and primary care. So this is what we can do beyond what is already happening at the Healthcare Cost Transparency Board, I anticipate. So it's going beyond a spending target, Mandy?
I think in some ways, and I think in some ways, some of the items on the list could simply be a cross-pollination of other things that are happening.
Yes.
And so I think the intent of the commission members in putting the items on the list could be to hear and support some of the efforts already underway. I suspect that that's the reason why they made some of the lists. And when I look at the list, I envision like some of this could be supporting the work of other things that are underway. It may not take a significant amount of time of commission members, but supporting the work of others.
Okay. So
And
it seems like
Mandy,
that's,
sorry, Jane, would that include the primary care certification, the kind of aligning payments across different insurers for primary care? Because I feel like that would be a motive. Or is that more with the other
However
one?
you would like to tackle it as commission members, I think it could include a lot of items and a lot of work that you're taking. We could hear about, a wide variety of items on each topic and then support those work efforts or engage in those work efforts if we'd like to.
right. So it seems that, Vicky, your statement about aligning primary care payment in a multi-payer approach and motivating interest in preventive and primary care. Washington State is one of the states that's participating in the CMMI Making Care Primary demonstration. So clearly, we could be supportive of that effort because it's a multi-payer approach to primary care. And then the spending target, it seems like motivate interest in preventive and primary care. And there's the whole primary care advisory committee of the Healthcare Cost Transparency Board that's focused on that. So there, it seems like, we're sort of like, yep, we're backing that up because though that's a critical component of moving toward the system that you would want to see. On slide 6.
We already talked about these ones right here, right?
Right. And then the last 2, provider rate regulatory approaches and consolidating and expanding state purchasing. Well, the study of provider rate regulatory approaches, you'll probably hear we're going to talk about as part of the affordability study.
Okay.
So that links to that.
Okay.
And I'm
just
thinking,
making notes here. Yeah. So
yeah. I mean, it seems like consolidating and expanding state purchasing is one place where we don't, other than via Making Care Primary, where we don't see sort of a clear pathway that's already work that's already going on. So maybe as a priority for us, where it's something where if a lot of other folks aren't doing it, then it's a good thing for the commission to prioritize resources on. So it's just a way to think about it.
Jane, I just have a question. Is the last one where state provider participation intended to be grouped with the other one? Because just according to the column on the right, it says increased access for publicly funded programs, which seems to be slightly different than the first two, which are wider spectrum.
Yeah, I had not lumped that one in, Liz. I think when you were sweeping with the cursor, it
Okay.
sort of got swept in. I mean, that might actually relate back to the previous slide where we were talking around building on programs that are already operational in the state.
What do folks
There-
think about that? Yeah. Say that, keep talking, Jane, sorry.
I'm good. I want to hear from other people.
So just to kind of recap, I'll go back and forth between these slides because that was a lot. So what we just discussed was the first three: auto enrollment, codify and fully fund the health expansion, and increase participation in Medicare savings. These would naturally go together because they're an expansion or maximizing current existing programs. The pink ones collapse into one, and it sounds like there's going to be information coming out from some work that is happening, I think, in OIC. Is that right, Jane? Great. The blue: motivate interest in preventive care. We can add a lot more to this one, including multi-payer efforts, and managed care plans, the healthcare cost transparency board work on primary care, and the making care primary effort that healthcare authority is doing. And then we would add the state provider participation into one of these. Which one was it? This one, the motivate interest in primary care. Did we think it fit in one of those? And then we've grouped provider admin simplification and standardizing claims. That was Representative Schmick who got the ball rolling on that. And then we have the study of a provider rate regulatory approaches, which will be included in the OIC work that's happening on affordability. And finally, consolidating and expanding state purchasing. That's kind of its own bucket. There's not a lot of effort anywhere else. It would be a really great topic for the commission to dig in on. And we did hear that from one of the presenters on FTAC about there are a lot of challenges to this, but definitely something worth diving into. Vicki.
And that's one of the ones I'm interested in. Also, like you said, don't see any other work in the state going on in that. And I wonder if that aligns with the very first one, the continuing coverage for Medicaid, because I think we want to expand PEB and SEB if we can. I see Dave's hand up already, and then expand Medicaid too until they kind of like merge together. I think in my mind makes sense. But I don't know what the legalities are of expanding PEB. Like, I run a very small Washington State nonprofit, and our insurance is crazy high and our deductibles are. We hear from other people on small businesses about the unaffordability of their coverage or trying to purchase through QHPs. So that's just what I have to say, but I'd love to hear what Dave has to say.
Yeah, I was going to say, I also agree that there aren't many other places that are talking about that last one, and it doesn't fit anywhere else really. But I kind of follow the same thought that Vicki was having is, there's this, if we're going to end up in anything that's in the I say this a lot to a lot of people, if we're going to end up anywhere on the single payer universal system, we've got to keep consolidating things together, and there will have to be a collision course of Medicaid and commercial at some point in order to get over that, to get to that end state that is anywhere on that side of the spectrum of this entire conversation. And Vicki, to your question about kind of expanding PEB and SEB, there's what I think is the low-hanging fruit, which is other public purchasers. The thing about PEB and SEB is they are governmental plans, and so they have Public Health Service Act instead of ERISA, which is just, I always say, die at ERISA. Usually that gets a smile out of Jane. But you can continue to expand a lot of different aspects of public purchasing. We have mandatory participation by different parts of the public sector, and we have voluntary participation. And so there's, you know, a gradation of participation in PEB and SEB, and so there can be some natural expansion there. There are, I think, questions around private employers. You know, you have to balance eventually, you know, moving from Diet ERISA to Real ERISA if you want to consolidate that aspect of it, or do you do something that's more expansive with Cascade Care and public option, since that really is the space that we have right now in the state for non-governmental employer purchasing. But, you know, there isn't really somewhere else that's talking about that too much, and that's why I think it's a good one. I think you could start to lump it back into, like you were saying, Vicky, on the prior slide, at least closer in proximity to some of the Medicaid pieces than further away in the conversation, just for that inevitable collision course that I think you were describing, that I agree eventually needs to happen.
Dave, and I appreciate the mention of public option and Cascade Care as well. I do think that's in this mix of like Medicaid, the Cascade Care tools, and with PEB and SEB, I do see that as a continuum as well.
Yeah, back in the late 90s when I was at the Jamestown Tribe, we bought basic health non-sub for our employee insurance plan, and it was the best. So yeah, if that's connecting it to Cascade, that makes sense.
Great. Okay. And then what about other commissioners? Any comments? Megan.
Hi, so I'm still pretty new.
Yeah.
So if you can just explain a little bit to me, what are the options that, because, you know, we can get people covered, but the coverage is sometimes terrible, right?
Yep.
And then there's I'm not sure if the state provider participation is where we skip the insurance and go directly to providers. Like, is there an option for that where we're no longer going through insurance agencies to cover people's health care?
Well, I think these transitional solutions are about trying to build on the system that we have, or leverage or get the best out of what we currently have, which is largely an insurance-based system. But I think where we could eventually go in the universal design is, and I think we should probably do an orientation. Mandy, I don't know if we've done an orientation with our new commissioner, but to kind of understand the different options that are available and sort of some of the gray space between full single payer and where we are right now. So trying to kind of build a pathway towards that based on what we currently have.
So just for me, and maybe an orientation would be great,
Yeah.
but if we're building a path towards that, what is the time frame we're dealing with? Like, are we thinking we'll be getting there in 5 years, 10 years? Or are we looking like, you know, because I think that's important. If that's utopia, if that's like,
Yeah.
You know, where we want to get, then we need to have a plan to get there that has a time frame.
Yeah. Well, that's great input. No, thank you.
Oh, was that? Oh, okay.
No.
I don't know if I was saying something that someone's already said. I'm sorry.
No, I think yeah. Representative Riccelli.
Well, I'll start by saying, I think maybe Liz is answering the fact it comes down to a lot of the political will that, you know, has to be mustered and from these types of conversations, that timeline, and we're subject to these short-term 2-year and 4-year type outlooks and not looking for the long term. So I'm hopeful that that's kind of the direction that we're headed, that we can get to that time frame. I think that's what a lot of people are. So with that, I just want to echo what Dave said. Low-hanging fruit, great. The more he knows, I've been cheering on every time he talks about SEB, PEB, rolling folks in. And if I miss this, I apologize. And I thought maybe Joan was going to jump in, but maybe she's being careful. But, you know, HCA is looking at the standardization of the plans that we already have. And I will probably get my inbox in trouble with teachers and state employees. But like, at some point, looking at plan designs and making them standardized across all, I think that's the goal, right? And so I'll just say that and subject myself to a bunch of angry emails, possibly from folks, but also understanding that makes a lot of sense on the exchange, that we don't need all these different plans to be marketing themselves, and it's just causing confusion. And if we can have that design occur and then start looking at those differences between our PEB and SEB plans, et cetera, then I think we're making things a lot easier for consumers and we're creating a better path. So if that's already been said more eloquently and I missed it, I apologize, because I just stumbled through that. But
Definitely wasn't said in any way better by me. I would say that it dovetails in the conversation we were just having about, Dave raised PEB and SEB and consolidation of the markets, and we're looking at this continuum. And when you shop for your PEB and SEB coverage, you're choosing between 2 and 3 options. It's like a PPO and there's sort of one and then another and then something in the middle. And Dave, I'm sure, has stories of people, angsting about those 3 choices. And when you look on the exchange, there's 30, 40, 50 plan choices. So I think trying to take lessons learned from PEB and SEB and apply them, to the individual insurance market, and then expanding on those to further look at lessons learned from basic health and lessons learned from public option over the past 3 years, to further sort of consolidate and simplify and then connect, is sort of, to me, what these transitional solutions are. Yes. And then you look at the different incentive structures that are built in there, like the Cascade Care Savings Subsidy, and like the legislative tools that were part of Cascade Care, and like some of the work that's being done around affordability. And eventually you can kind of stream them all together, even though they're all getting advanced through slightly different channels. So I think it's well said, and it definitely wasn't said before. So
100%. Mohammed.
Thank you. No, this is a great discussion, and I really appreciate that. This is built on the conversations that we've been having, the last 14 meetings. Maybe I was thinking I'm afraid we might end up with something that basically responds to all of, checks all of our boxes, but might take a little longer to implement or see the benefits for a lot of Washingtonians. When you talk to everyday Washingtonians, and some of the comments today too, our processes might be taking way too long to save people that might really need to have coverage right now. And maybe we can add another column, which also tabulates this. This is how long it will take us to get there. Maybe a separate criteria that looks at the timelines, depending on what we've built on up until this point.
So adding a column about how long we think it would take.
Yes. So yes,
okay.
that is, yeah.
Well, and I think that's something that, unfortunately, I don't think that our team right now can say how long it would take. I think that what we would want to have asked during one of the presentations, if we spent time on this, is how long would it take to actually make this happen? I think that's a really good question, because some of these things, I mean, in that we, tried to put it in terms of resources required or magnitude, how, what kind of impact it would make and how much money it would take or political will it might take. But I definitely think that, if we say we're going to look at these over the course of the next year, I think a key question is how long would it take to actually make this happen? And I think, again, we're saying that these are topics we want to tackle over the course of the next year and make a recommendation for the report next year.
I just want to check in.
Yeah,
with
time,
Nicole
I know.
And Senator Randall, because we haven't heard from either one of you.
Yeah, I'll just say that I actually agree with I think, goodness gracious, I'm going to totally, network adequacy standards should be included with the other 2 that are in blue, if I recall. Was that what Representative Schmidt was referring to earlier?
Is that what you, okay.
I believe so.
Okay.
Yeah, other than that, I mean, I actually agree with those 3 as well as being my top 3. to start. I think those are a little bit easier lifts than some of the others at this point.
Okay, and I see Jane's hand up again, so.
Right. And to Mohammed's point, one way to look at it is having the commission opine on how long we think it should take to do these, to put these transitional strategies in place. And Representative Urcelli's absolutely correct. The legislature thinks in biennia, in 2-year or maybe 4-year periods. So maybe thinking about, you know, this should happen in X biennium, right? To make a little more concrete the ideas and maybe then when you're thinking about ones that are grouped together, right? It might be, what is the strategy? You know, are they all done in a single biennium or is it a 2 biennium strategy? But Representative Urcelli, you can tell me whether I'm blowing smoke on that one.
No, actually, I did project management for like 5 or 6 years, and I can see that block chart right now of like this biennium, if that doesn't happen, but you could, I think what we want and what people want is to be able to wrap their arms around something if we're moving forward in these chunks, because I know that's hard. I hear the frustration from the folks who are talking about real life issues that come to give public testimony. And I've really struggled with this personally, as how do we keep on this long track, just looking at the legislation, looking at the provisos we want to have done, looking at setting up the commission in this, with also doing what I think are very tangible things that we're suggesting here. And I think one of the ways that we can do that is with this kind of outlook of a timeline, so we can see the things that we're doing to put us on track and seeing if we're falling off. So I think I'm saying the same thing you are, Jane. And I really wanted to our to Megan's point to also just say, like, it's very frustrating, and I would love to, you know, say that we could, Director Matthews, I would love to say that we could snap our fingers, and I think you're hearing that. We're all hearing that from the public. So I think we are pushed, and we need that pressure too to stay on track. And so trying to find how to navigate that is difficult, and we should push ourselves. And I think we all probably heard Senator Hasagawa's, you know, put a number of things forward. So just navigating the politics around this are very challenging. And I hate to bring politics into good public policy, but it turns out it's permeating all this.
Great. I know that. Oh, go ahead. Go ahead, Dave.
I really think it's important that we reinforce both Jane and Rep. Urcelli's comments about thinking of things in biennial chunks is extraordinarily important for absolutely making progress. Representative Urcelli, I know you were just being a little bit tongue-in-cheek on the not wanting to bring politics into it, but the reality is that politics is part of the process, and the only way to really advance large policy goals is to take them step by step, biennium, because if the pendulum swings too much, you can look at SEB as a classic example. In 1992, there was legislation that consolidated active and retiree employees. And then election happened, policies changed, retirees were consolidated, school employees weren't. It took 30 years for that conversation to circle back and get over the finish line. And one of the reasons I think, as the person who helped being responsible for leading that consolidation, was it was contained within a four-year, 2 biennium period. There was only, you could show progress in the biennium, get one more final buy-off on the funding in the next biennium, and then it was kind of done. And we've been on that path for 4 years. You have to think of things in those kind of realistic, tangible, show progress chunks to be able to make headway on big policy changes like this. So I think it's really important to reinforce that biennial frame as we think about what to recommend in incremental steps. Everyone wants to flip the switch. There's a lot of momentum for flipping the switch, but the reality is there are steps that have to be taken in order to get there, and thinking of them in bienniums is, I think, so critical.
Right. Okay, Megan, and then Director Matthews, and then we have to, Vicky's telling me we need to move to the vote thing, so.
So I think for me, I really I like the plan. I like a timeline. However we chunk it out is fine, because you can be intentional. And you know, HCA Office of Equitable work with you. We are state agencies, so we have the time. We're not bound by 2-year, 4-year chunks. We can actually plan this out and present this to the legislature to say, here's how we plan to do this. And I think it's upon us to do that. So I would really love if there's meetings we need to have outside of this. I don't know if that's allowed. I'm sorry. To like come up with a plan that says, here's where we are. Here's what we can do with I like the poverty reduction work group. They said, maximize the system we have while we build the system we need. So how are we doing with right now? And the folks talking about the folks who are losing, I dealt with in my own family. So this is very, I understand, right? Where you're having to choose, well, can you live? Can you live? I mean, that's a question people are grappling with, and so many people can't. And so I think we, as a state, I'm talking to my state colleagues here, like whatever we need to do to create the plan to get to where we need to be, to present that to our representatives, members of the legislature, on the call set, they have something tangible we can move forward in the chunks. I think is something that we need to do. And sorry if I'm like late and y'all had already talked about all this, but if we haven't, like, I really think we need to do this.
So many things. We do have a plan for transitioning through universal healthcare. It's sort of broken into 5 different increments. I'd be happy to take that with Liz, and I will do that during your orientation.
Okay, so I think you ready to go, Vicki?
I just really quickly want to check in with Senator Randall because we didn't hear a word from her. And is she still on?
Oh, there she is.
Sorry for calling you out, but
Yeah, no, it's okay. I knew you would, so I had like gotten ready to jump in. I've been really enjoying sort of following along the process of both newer folks to the commission, but also some of our the seasoned experts in the work. And I really agree with sort of the chunks that we have zeroed in on. Really excited about the provider simplification. I think we hear loud and clear from docs and providers that is a burden. We hear from community that is a burden, and I think it will help us build momentum and really highlight the need for continued path forward. I'm like, my favorite solution is as we do the PEBSEB Medicaid merge and get towards a future where we're covering everybody in these bigger systems. I know that that's like a heavy lift, resource wise. But I love the idea of having that on a chart as one of our goals, and seeing which biennium we think that we can do that in. And this feels like a exciting meeting to sort of lay out this vision.
Thank you. So I think we've got 3 colors, and then we got the state provider participation. Does that go with the yellow? Maybe. And then we're just going to divide the 3 colors and vote on them, I think would be the most simple way that I can think of.
We did.
Sorry,
we can just put that one there for now, but.
Okay. So we have the yellow highlighted solutions, and then turquoise, and I'm going to say magenta or pink.
Some type of pink. Yeah.
I just wanted to say magenta because it doesn't get used a lot. So then we're gonna vote, and I'm trying to think of the best way. Maybe.
Well, I think these two magenta ones are going to get addressed through some work that OIC is doing. So let's take them off, and then the last one is the rate, and the study of provider rate. That's also OIC. Okay. So magenta is off. So now we have these blue ones right here, which are simplification focused.
Mm-hmm.
And then the preventive and primary care. And then we have the auto enrollment, the ones to maximize current programs. And then we have the consolidating expanding state purchasing. So
Liz, and can you remind me, by saying, the question was around address first, second, and third, can you remind me what timeframes are envisioned there in terms of order?
Right. In terms of the way that it's worked in the past, and because we have more time in the meetings, I'm hopeful that we'll have more time for these conversations. is that, and Mandy, staff, pipe up if I'm wrong, the draft report gets done in like June, July. So ideally, you'd like to have something to say about these topics for the next report. So by July. So we have 3 meetings between then. And so we could probably spend one on each of these.
Okay, got it. I was just thinking the unwind. I don't know if these comments came through earlier, and I'm sorry for dropping the unwind goes through April, right? And so in talking to California and just practically speaking for the auto enroll piece, we'll be looking to our state colleagues in California and otherwise to see how it went and how things were going with the pilots following open enrollment and through the spring. So anyway, just throwing it out there as a note from a timing perspective that at least for that first one in the yellow, we're going to be learning through open enrollment in early spring.
Jane, I saw your hand up. I'm typing notes from Joan's comment, so.
Yep. Okay. So one thing I did want to say is in terms of like the BBPA services not covered by BBPA, uncovered ambulance services, and looking at rate regulation, yes, those are subjects that are coming up in the upcoming legislative session, but it's a 60-day session, right? And if nothing happens with those issues during the 60-day session, or if there's no indication of movement forward on those issues, I would suggest that we revisit this at the end of session and sort of say, okay, what happened during session?
Okay.
And how does that influence, if at all, how we're prioritizing and working through these issues?
That makes good sense.
That does make good sense. And I think one of the things we did commit to at the last meeting also was getting more regular updates on what's been happening. So at the end of session, hearing what was the fallout, what are the gaps, what changed, like, is there a good thing that happened? You know, is there more money for covering immigrants or something? Okay. Magenta visit. So then I think that really then the question is about, and Joan's comment was that we should wait to talk about these ones here, these yellow ones, until after April. We'll want to get
well, and Liz, I'm not sure about the last 2. I would welcome HCA
Okay.
commenting on those, but I do think with the Apple Health, it goes a little bit to the legislative comment that was just made with the Apple Health expansion that's happening in July, and then with auto enrollment into, you know, with these sort of lessons learned from the unwind and these pilots, we won't really know much more until the spring. So anyway, just thinking for consideration in terms of timing, but not sure quite how the MSP part fits into that in terms of timing, but it seems generally speaking for the other 2, we'll be getting to the substance of it in the spring and summer.
So, and I also did hear, I think it was Nicole or Senator Randall that said the 3 network adequacy, provider, admin, SIMP, and standardized claims. And we heard that from Representative Schmidt. Those seem the first priority. So, okay, so that's what we heard. That's what number 1, maybe consolidating, expanding state purchasing, number 2, and then number 3 is this grouping of yellow here around auto enrollment, because we'll have some information. And then also around that same time, update on the pink from the legislative session.
Okay, so 1 is providers, the simplification, right?
I'm just going to put it in here so that we can all track.
Okay. Thank you.
Sorry, I'll watch me type. I know this is a lot of things to track, so click it. Okay.
I think we should just take it one at a time and just see how commission members feel like the first one is the right one, and then we can move on to the 3 topics maybe.
All right. And we want to do, well, we'll do ayes and nays, and if there's a lot of nays, we might have to have more conversation. So the proposal is to take the block of provider simplification solutions as the what we want to address first in 2024. So All those in favor, say aye.
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 All right, and those opposed, say nay. Okay, so we're gonna do that one first. And then for the second one, we were looking at the consolidation and expanding state purchasing. Is there any conversation on that? Okay, for this second topic the commission would like to address in 2024, it is proposed that it be consolidate and expand state purchasing. All those in favor say aye.
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 I would. All those opposed, say nay. Okay, so that's our second one. And then the third one, which this will get us after session, right? Is that first block there, the auto enroll. What do we want to call that?
Maximizing current programs in place.
Thank you.
Including
Maximizing
Care,
current program
exchange, etc.
So the third topic we would like to address 2024 is maximizing enrollment in current programs. Did I get that right? Maximizing current programs, and that, waiting till after session. So is there any conversation on that? All right. All those in favor say aye.
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 Aye. Any opposed? Say nay. All right. So we've got our three priorities and the order which we're going to address them for next year. And it's a little more than three priorities, but thank you for helping get us to those.
Yeah, I mean, I think there's going to be a lot of great discussion about these topics. I mean, I think it was hard to not get into the details on them, but lots of opportunities. I will go quickly through the next one because I think it's actually pretty easy, but just to remind everybody about like the second charge, which is the universal design. We've been really focused on the foundational areas. We tackled eligibility. FTAC has really provided some good guidance in terms of not whether or not folks are going to be eligible for the system, but really about how to tackle the financing. And it's been, just to sort of recap this last year, they've made the decision that while they know they can't, that ERISA plans and Medicare can't be included at the outset, they do want to ensure parity for those, for individuals in those programs. So they've set them aside, but once the benefits and services are selected, then looking for a way to try to align those benefits and services and creating a pathway for parity. So the next topic that the commission has agreed to focus on has been benefits and services. And I think the question on the table today is, we're in the process of developing a grid. I think FTAC provided some input on this and also commissioners a couple of months ago about wanting a grid that compares the benefits and services in the various programs that people are currently enrolled in. So what is the standard Medicaid package? What does Medicare include? What is, I'm sorry, not Medicare, but what do public employee plans include, so that we can have a visual that shows what the benefits and services are as a starting place for those conversations. So first question is, are there other resources or tools that could be helpful for this discussion around benefits? And if you don't have an answer today, I think you can also provide feedback to Mandy and the staff via email, because it's a pretty complicated topic, but we are planning to at least do that grid. And then the second question is, what should the role of FTAC be in this conversation? Last year, the commission identified the topics and asked for specific guidance and TA on very particular questions, and just wanted to check with the commission if they would like to continue having the FTAC focus on the universal design components, or if they would like the FTAC to focus on transitional solutions.
All right, oh, go ahead, Jane.
So can we go back a step, Liz, to the previous slide?
Yeah. This one?
Okay. The benefits and services one.
Oh, this one.
So, right, that one. So here's one thing to think about. It might be helpful when we think about PEB and SEB to think about them, and Dave would love your thoughts on this, as sort of a typical large employer plan. Because the vast majority of people in the state get their coverage through large employer health plans, not vast majority, but a big chunk of people. And we're doing the essential health benefits update, and sort of the way we're thinking about a typical large group plan. PEB is sort of the most generous among those, but it at least gives us a sense of the scope of benefits for some of those plans.
Yeah, Jane, I think the qualifiers you kind of just put in there at the end are important to remember. But I think it's fair to say that they can be a benchmark of plans. And I think about in the creation of SEB, we did some comparisons of, for example, smattering of school districts to kind of show where SEB was shaking out in relation to the experience that school employees were having pre-SEB in different parts of the state. And so in no way would, that we were benchmarking or describing in that context. And so I think it's important to identify a plan or plans that can be that. And I think it makes sense that there is that PEB and SEB can be used as that proxy. Maybe we go back to, I think we've determined at some point, Jane, that somewhere around 19-20% of the commercial market is in PEB and SEB. And so that's what we talk about at HCA, is when we're purchasing on something and we're having the same standards of purchase contracts in both Medicaid and PEB and SEB, then we're influencing the whole delivery system. We're not just influencing our slice of the market, we're influencing the entire market, because providers and systems aren't going to change for half of their population. They're going to do the infrastructure changes for all their population. So I think it's fine to use it as a benchmark, like you were, or a standard comparison, as you were saying, Jane.
So,
thank you.
Okay. Go ahead, Nikki.
Well, what do we want the FTAC to focus on? And I appreciate that kind of narrows down maybe what we want to focus on too. Do we want them more focused on universal system design or on transitional solutions? Mohammed?
I'm gonna ask a silly question. What is there a reason we can't ask them to do both?
Nope. That means they'll do less of each, right? If they do both.
It does help for them to probably be more focused, but I mean, I think the true question is, what does the commission want to focus in on? And then what then should FTAC be focused on? Is the commission in the upcoming year more interested in exploring transitional solutions, or would it like to be more interested in benefits and services design?
I sort of feel like we need to do both, right?
Well, both
I
will
don't think
happen.
there's,
We're just asking which might be the focus. We're just trying to come up with a work plan, and we need to figure out how to run FTAC and the commission and who's going to be doing what. And so, last year the commission's focus was on the transitional solutions, and FTAC focused in on the universal healthcare system and then reported back to the commission on its progress. And so is it the same in this coming year? Or is the focus of the commission to shift this year? Would you like to do something different?
Okay, so let me rephrase the question. I guess Mandy said it. We have where the FTAC continues their focus on universal system design, and then we work on transitions, but we keep getting reports back from them and can instruct them if they have questions. Would you say that was describes what's been going on in the last year?
I think that's a fair summary.
Well, and I think Mohammed's point, it's not that last year there was the commission did ask FTAC for support on some of the transitional solutions in the beginning, so it's not off base at all to think about that. And I think I think one thing is that we haven't, I guess, fully digested is that there is additional time for both of these groups in their meeting time. And I think part of the reason we were so linear about keeping things like that was because of time management was a big part of it. So I think there's a way to maybe do a little bit of what Mohammed is suggesting.
And that isn't to say that those questions can't go back and forth between the commissions, but it's more about the focus of the work. Like, where would the commission like to focus its efforts this year?
I mean, one thing I would think about is, given the composition of the FTAC and the number of folks there who have national sort of and more methodological and research expertise, it makes sense to keep them focused on universal system design issues as long as recommendations are coming back to the commission, so that the commission isn't focusing exclusively on transitional solutions, but is making decisions based upon what the FTAC is bringing back to us.
Yes, and we'll continue to get an update from Pam from the FTAC every time we meet, and they can definitely send questions and clarifications back to us, but it's the work that we've assigned them. So I guess the vote is keep things the same, okay? So should I make that a little, let's see. In 2024, shall we continue, well, the FTAC's focus on universal system designs with updates to the commission at each meeting and clarifications made, and then the commission really focuses on those transitional solutions.
I'd offer a friendly amendment, Vicki, that it's not just updates to the commission, but it's bringing recommendations to the commission for votes.
Okay.
Also.
Yes.
Yeah, I think that structure is still the same for FTAC. The commission directs its work. We would still do the same, where we ask the commission what questions does it have related to these particular topics, so that FTAC can dive into those as instructed by the commission, and then brings those back for recommendations, answers and recommendations.
Yes. Is everybody clear on that? Okay. Any other discussion? All right.
No, oh, I'm sorry.
Go ahead. Nope, go ahead.
Oh yeah, no discussion. And so I'm just a little quiet on this because I was trying to think through on whether or not the transitional solutions are those, I guess we're assuming those are in the purview of the FTAC. And I was trying to think back on what their original charge was. But all that to say, I agree with the direction we're headed and keeping their focus. So thank you.
Thank you.
Well, and I mean, I will say, from having gone to those FTAC meetings, the FTAC members are not at all shy about opining on other things to give you all their input about the universal system and how it relates to transitional solutions. So I think we can probably be more intentional about trying to draw connections between the transitional work and then the long-term work, because they're thinking about that already too, just because I think that's who these folks are.
Yes. Okay. All those in favor say aye.
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 Any opposed? Oops, sorry. Any opposed, say nay. Okay. Well, we've got the FTAC focus for 2024. We are 20 minutes behind, and so I'm just reminded, I asked if maybe you wanted to stay. So we have 2 more presentations. I don't know if people can stay an extra 20 minutes so we can get them both in. The first one, we have the whole Washington is going to share their eligibility as envisioned by the whole Washington Trust. We have Andre Stackhouse and Aaron Georgian. Am I saying that right?
Thank you. I'm going to go ahead and share my screen, actually, if that's okay. Okay, great. So thank you for having us back to present. This is a continuation of the overview that we gave on August 10th. And we're back to talk about the Washington Health Trust and Senate Bill 5335, specifically with its regards to eligibility. We were asked to give some more details on some of the harder questions of how we make this transition. So you can view this presentation and our last presentation at wholewashington.org/UHCC-presentations or email us. Before we jump into the eligibility stuff, we wanted to give a little bit of context about some of the expertise that has gone into this. So first of all, my name is Andre Stackhouse. I'm the Executive Director of Whole Washington. Erin Georgian is here to help us answer questions today. She's one of our policy consultants. But the Washington Health Trust was originally based on the Washington Health Security Trust, a bill developed by our friends at Healthcare for All Washington and introduced into the state legislature many times. We also took inspiration from federal legislation like HR 676, federal Medicare for All legislation, and developed components from existing working models out there in the United States, like Healthy San Francisco, which is a city option. We had our plan vetted by the Employment Security Department and the Department of Revenue, and have run 2 financial analyses with Dr. Gerald Friedman, Professor of Economics at UMass Amherst, and you can read the latest analysis on our website at the link below. So for today, we want to talk about eligibility in the context of a universal healthcare system, specifically in Washington, roadmap, how we can achieve universal eligibility and integrate existing programs like Medicaid and Medicare, and then also talk through known barriers like ERISA. And this is part of an ongoing collaboration with this healthcare commission. We would love to continue the conversation with a more detailed discussion of the financial considerations with the FTAC. And ultimately, our hope is to co-develop real universal healthcare policy that gets recommended to the legislature and voted into law so we can actually get people the care they need. And we're continuing to use the design components developed by this commission. So you can see eligibility on this gear down here. And all of these topics deserve further examination, but we'll do the best we can with the time we have here today. So starting with the definition, we like the World Health Organization's definition because of its flexibility, and it identifies important key outcomes that we hope to achieve. And the very first one, and rightly so, is universal eligibility, either through enrollment or automatically. And we're really going to focus mostly on voluntary enrollment because there are legal reasons why we can't simply automatically enroll people. This diagram shows that we have a sort of complex system that we're dealing with. So this is only the public plans available to people. So you see familiar plans like Medicare, Medicaid, Cascade Care. And we propose the creation of new programs such that everyone in Washington is eligible for enrollment in a public plan. And so our hope is that we can create a simple front end that combines easy enrollment, uniform billing, and a single essential benefits package across all of these plans. So that if you're a provider or you're an employer or you're a resident, you know I'm eligible to enroll in a state plan. I'm going to be covered by that same single essential benefits package. And you don't necessarily need to know all of what's going on the back end. Am I covered by this program or that program? Where does the money come from? That's something that really needs to be handled by the state and its administration of this. Over time, through the acquisition of waivers and walking a transition plan, we can achieve all of this in a truly single and unified program, but this is something that can only happen through sustained effort and will. Enrollment is not something that is highly specified in 5335, but the responsibility and authority to implement that is given to the Washington Health Trust Board and the Healthcare Authority, and can be done through existing infrastructure like Washington Health Plan Finder, and really encourage the creative use of existing infrastructure like hospitals, the DMV, public libraries, voter registration. There are many places where this public outreach can be done, where people can be informed about this and enrolled. So starting with the stakeholder group individuals. So again, the idea is that all Washington residents would be eligible, and we would use the state definition of eligibility, which is 30 days. There would be some eligible non-residents, including students attending college in Washington, workers who may be employed in Washington, but who do not necessarily live in Washington, as well as spouses and dependents. There are some family situations in which a non-resident may qualify as well. And right now they're getting their coverage through mostly employer-sponsored health plans, but also some of these public plans. There's also the exchanges. And then, of course, too many people are still uninsured. So how do we create eligibility such that people getting their coverage from all of these places can participate in the Washington Health Trust? So starting with Medicaid, we don't see substantial obstacles to enrolling Medicaid recipients. We have a federal innovation waiver to give us flexibility. There's already a robust enrollment system through Washington Health Plan Finder that we think actually provides a great model for enrollment for everyone. But the main idea here is we can begin by raising the coverage of Medicaid up to that single essential benefits package, which would cover all medically necessary care. We would raise the reimbursement rates. And through the acquisition of Federal Waiver 1115, we would be able to fully integrate Medicaid into the Washington Health Trust rather than manage them as two separate programs. Medicare is a little bit more challenging. It is a federal program. We can't simply take that federal money and put it into a state plan. We can't just take those enrollees and put them into the Washington Health Trust. Long term, we believe we can fully integrate Medicare into the Washington Health Trust through the acquisition of a federal demonstration waiver. But in the immediate future, we can simply allow Medicare to continue to function as it does today. And in the sort of more medium-term future, we believe we can supplement Medicare with a publicly funded and managed Medicare Advantage plan. So through that supplemental plan, we would be able to raise the coverage of Medicare up to that single essential benefits package and give Medicare enrollees a way to voluntarily enroll into the Washington Health Trust. So this commission has looked at 6 different options for Medicare integration, and we're basically proposing that we pursue 2 of them. So number 2 is that federal demonstration waiver, and number 4 are the Medicare Part C and D plans, which would allow Medicare enrollees to enroll in a public plan that would give them their dental, vision, hearing, and prescription drugs. And one thing we always like to remind everyone at this point in the conversation is that we cannot apply for or acquire those federal waivers until we pass legislation. The waivers must apply to existing legislation. So it's legislation and then waivers, not waivers and then legislation. The exchanges. So right now, the way we see the exchanges is that effectively it's public money, federal funds, and state infrastructure going to subsidize and sell private health insurance to the public. And we would prefer to see That applied actually to a public plan that everyone is eligible to enroll in which provides universal coverage. So our proposal to make that transition is once we achieve 51% enrollment across all state managed plans, and for context, we're already at about 40%, at that point, the Washington Health Trust would become the only plan on the exchanges to receive cost assistance. The exchanges could still continue to operate and private plans could still be sold on them, but we believe that but that's where the cost assistance should go. And then the Health Options Program. So this is part of our transition plan. And what this allows us to do, it is not an insurance plan. It is a direct reimbursement program, and it can directly reimburse community health providers as well as individuals. So as people fall into gaps during the transition, especially, so people who maybe are not yet enrolled in Medicaid, don't qualify, parts of the system that have not been rolled out, people who are uninsured or underinsured, we can simply directly reimburse out-of-pocket costs, or to community health providers who are providing care to people who do not have the means to pay for it, we can directly reimburse that care to those community health providers. So any services that are covered by that essential benefits package could be reimbursed through the Health Options Program as we transition them onto public insurance. Employers. So employer-sponsored plans are where most people get their care, and we want to encourage as much employer participation as possible. However, because of the federal law ERISA, we cannot simply mandate that employers who are providing ERISA-protected health benefits participate directly in the Washington Health Trust. However, we can require employers to provide health insurance, health coverage to all employees, including part-time, contract, intern, so all employees. We can create a required health expenditure per employee to make sure that enough money is going towards the health coverage of those employees. We can define what kinds of spending qualify towards that expenditure, and we can cover all children, which will really allow employers to focus more on individual plans and less on family plans, which are much more expensive and much more complicated. So this is our ERISA workaround, and it was modeled after Healthy San Francisco's city option, which has been implemented for years and has survived legal challenges on the basis of ERISA. So we're highly confident in its feasibility and its legality. This shows how this design actually provides a lot of flexibility to both employers and employees. So there is a required healthcare expenditure. It is 10.5% based on employee compensation. So the higher the compensation of an employee, the higher the healthcare expenditure. But it can be allocated in different ways. So private insurance counts, so does the long-term care tax, and many employers are already meeting or exceeding this healthcare expenditure if they provide insurance to their workforce. If they are beneath this expenditure, the difference would be paid to ESD directly and fund the Washington Health Trust. But we really think that the beauty of this design is that every employer will have the option to simply pay 10.5% to ESD directly and have their entire workforce covered by the Washington Health Trust. And because this expenditure is the same, whether they're doing it through private insurance or through public insurance, we believe many employers are going to choose to unburden themselves of the administrative work and cost that goes into providing private health insurance and simply opt to pay the 10.5% to ESD and cover all of their employees. And also, this can be done for all employees or on a per employee basis. So some employees could be on the health trust, some could be on private insurance, and an employee can choose to opt themselves into the health trust, even if their employer offers private health plans. And then providers. So providers participate in this simply by accepting reimbursement. So all licensed providers are eligible to participate and receive reimbursement, and they cannot be denied reimbursement for any services they provide covered by the essential benefits package. And all they have to do is accept the fee-for-service rates set by the whole Washington board. Actually, the Washington Health Trust Board is going to negotiate those reimbursement rates with providers, but only participating providers. So this provides a very key incentive for providers to participate, because if they want a seat at that negotiating table, if they want to be a part of the rate setting, then they will have to participate in the Washington Health Trust. So we believe these solutions are legally sound. We believe that because they're designed around voluntary enrollment, that it will allow us to make this transition over time. It does not all have to happen on day one. There are mechanisms built in for community input and public transparency, and there are regular assessment periods in which this design can be adapted and improved. We believe that this plan is highly realized legislation. It has a financing plan, it has a transition plan, and it is ready to implement. But and we propose a highly aggressive transition in a single piece of legislation. But we want to emphasize that we understand that this is complicated, that this is difficult work, that this is a long-term project. And so for us, the most important thing is that we begin. And there are many places to do that. There's the creation of the trust, the creation of the board. There is putting that Medicare Advantage plan onto the marketplace to give people that option, or putting that public option onto the exchanges. And this is our year-over-year transition. And you can see in year 2, that is when we really believe that all Washingtonians should be eligible to begin enrollment. And if you work backwards from there, if you're enrolling people in year 2, in year 1, you have to raise the revenue, you have to commit to the essential benefits package, you have to create the enrollment infrastructure. But instead of breaking this down year by year, step by step, I wanted to end on sort of an analogy, which this is one of Washington State's mega projects right now, the light rail system. It is a long-term commitment, but it's one in which everyone understands that there is long-term commitment to this project. There are timeframes and deadlines. There are regular public updates where people receive a flyer like the one you see on the right in the mail. And there's visible and usable progress. And I often get upset when I see, oh, there was a delay on this, right? But we understand that deadlines are not always met. Plans change. And the most upsetting part about it is that we want the light rail system to happen. But the other important thing is that we see that it is happening. So we believe that this is the sort of model that might make a lot of sense for a long-term project like the creation of a universal healthcare system in Washington State. But with the time we have left, Aaron and I are happy to take on your questions. Thank you very much.
Thank you, Andre. Does anybody have any questions for Andre or Aaron?
Vicki, I'll just say thanks for the presentation, and Andre, I look forward to, we can happy to discuss offline sometime the vision for the exchange. The exchange and the vision for the exchange is all over this presentation, so we should chat about it.
Absolutely.
Anyone else?
It'd be really interesting to see the economic analysis. I think, Andre, you had a link to it in your presentation. So.
Yeah, we'd be happy to discuss it. And yeah, it's available for anyone to read.
Yeah, I'm on your website. I'm looking for it.
It's a pretty good read. In fact, it reads pretty comprehensively for an economic analysis.
Is there any chance you could just send like an Adobe of it or a Word version of it to Mandy?
Yeah,
so
absolutely.
that it can be shared? That would be great.
Thank you.
I'd be happy to distribute that.
Thanks, Mandy. Thanks, Andre.
Anyone else? All right, thank you so much, Andre and Aaron. We appreciate the presentation. and
Thank you,
hanging in
everybody.
there with our getting pushed back. So it is after 4, but I'm hoping that people can stay. I know a couple had to leave, but we have Jane Beyer to provide an overview of the Office of the Insurance Commissioner's preliminary report on healthcare affordability. And really good segue you got there, Jane.
Oh, okay. Okay, thanks. So I'm going to try to go through this quickly. We have Mandy, I think you were you able to put a link to the report in the materials that were sent out?
We included the materials.
Okay, great. Thank you. You can tell I've been on leave with my family. Okay, so I'm going to go through this pretty quickly. And I think these first 3 slides will be no surprise to anybody who is on the commission or who has been working on issues. Healthcare is not affordable, right? Employers have, in a study that we did of healthcare cost trends between 2016 and 2019, we had cost growth at almost twice the rate of inflation. Consumer survey that was done last year found 2/3 of folks were having problems in terms of accessing care because of affordability. And of course, we all know that healthcare is a massive portion of our state budget. Next slide, please. And last session, we know there were a number of pieces of legislation related to affordability that were proposed but did not pass. And so the legislature directed both OIC and the Office of the Attorney General to put forward policy options to improve affordability. And the report that came out last week were the preliminary reports, and there are actually 2 documents. One produced with the assistance of HMA for the Office of the Insurance Commissioner, and then the Attorney General's office did their own report focusing on competition and on merger and acquisition activity oversight, and also anti-competitive contract clauses. Next, please. So as you can see, we thought it was really important after discussions that we have with legislators to be able to sort of say, here's what the business of healthcare looks like in Washington state right now. And so a big portion of the report focuses on that, which I'll talk about in a bit. And then also an overview of potential policy options. And as I noted previously, the AG's office is really focusing on healthcare competition and policy options related to trying to strengthen competition in healthcare. Next, please. So in terms of the structure of our system, what we found is that 40 of the about 100 hospitals in the state are part of the 5 largest hospital systems. So those are Providence Swedish, MultiCare, Virginia Mason, Franciscan Health, UW Medicine, Peace Health. And then another 15 are part of smaller multi-hospital systems. And basically 80% of all the beds in the state are part of multi-hospital systems. And then what we've also seen is it's very common for the hospital systems to also, in addition to consolidating across hospitals, to integrate vertically. So ownership of skilled nursing facilities, you can see 82% of hospitals of those systems owned hospital affiliated clinics, 28% owned freestanding provider clinics, and 13% own a home health agency. About 50% of physicians are employed by hospitals, and of those 2/3 are employed by these multi-hospital systems. So we see again, both horizontal and vertical consolidation going on among hospitals. But then we also said, next slide, please, let's look at insurance, because clearly we should not be focusing exclusively on consolidation among hospitals. And what we see is that insurers are actively purchasing physician groups and clinics. And United Health Group owns Optum. And Optum, I saw in a recent Becker's report, now states that they employ 90,000 physicians nationally. And what we've seen is that health insurers or their holding companies have integrated across pharmacy benefit managers, the provision of pharmacy services, healthcare benefit managers, of course, acting as third-party administrators for self-funded group health plans, and then also even getting down into data and analytics. For example, United Health Group owned and just purchased recently Change Healthcare, which is a big healthcare data and analytics hub. And so we see that beyond acting as health insurers, these insurers are involved in a lot of aspects of actual care delivery in the state. Next slide, please. And then we started looking at private equity. It is really difficult to get information about private equity acquisitions, but the folks at HMA were able to get some information on private equity acquisition in Washington state. And there's a pretty specific business model that private equity uses when they come into an industry, including healthcare. And in a recent review of 55 studies, it was found that private equity ownership was most consistently associated with increased costs to patients and payers and mixed to harmful impacts on quality of care. And private equity seems to be most active in specialty care, especially dermatology, ophthalmology, gastroenterology. They're getting into primary care, OBGYN. You can see a number of specialties and also other healthcare facilities and services. So we're seeing them getting into long-term care, but also behavioral health in a fairly big way. So over the last 10 years, there have been about 97 private equity healthcare acquisitions in Washington state. And what we do see in Washington state are a couple of big private equity backed physician staffing companies. So Team Health, for example, is one of the 6 largest emergency medicine staffing companies nationally. And there are a significant number of hospitals in Washington state that are staffed by Team Health. And then U.S. Anesthesia Partners is a private equity owned anesthesia group. It operates in 8 states. And it is the largest majority physician-owned and led anesthesia group in the Pacific Northwest. So we see, again, just a growing trend of private equity acquisitions. And if anybody's interested, there's a great presentation that was done by a researcher from Harvard University, who's also a clinician, about how the private equity model works that we'd be happy to share with the commission. Next slide. So then we looked at affordability policy options. And of course, as you can see from this graphic, and as we've been talking about all along in the commission, given that people get their coverage through different sources, different policies address affordability for different segments of the market. Next slide. So what did HMA look at in terms of issues? The healthcare cost growth benchmarks, of course. We have our healthcare cost transparency board. It has established growth targets for the state of Washington. 9 other states have them. And we're waiting for the baseline expenditure report in the fall of 2023. One thing that is somewhat different about our board than the boards in Oregon and Massachusetts is that while our board can track healthcare expenditures against the targets that it's set, it does not have the authority to take action when a provider or a payer has exceeded the benchmarks, such as requiring performance improvement plans. Last year, legislation was introduced in the House Bill 1508, that would have given the board that authority. Next, please. Health insurance rate review. Many of you, I think, know that in Washington state, the Office of the Insurance Commissioner has prior rate approval over the individual and small group markets, and that under ERISA, we cannot require rate review for self-funded health plans. We review rates for large group health plans. So those are employers of 50 or more people. but we do not have prior approval authority over large group plans. One state that has taken action to try to more aggressively do rate review to influence affordability is the state of Rhode Island, which imposes a cap on the amount that hospitals can increase their prices each year. Also tracks and sets targets for primary care spending and has a process to do rate review and approval for large group health plans. Next option, reinsurance. Some of you may remember back in 2018 when the commissioner proposed legislation to establish a reinsurance program in Washington state, but it didn't pass. 17 states now have reinsurance programs, and essentially what these programs do is where you have a consumer that has very, very high costs, those high costs sort of get carved out of rates and get paid for through a program that is financed by both federal funds and by other financing sources, usually assessments on health insurers. So 17 states have done it. It's worked to lower rates in individual health insurance in 17 states. Next, reference-based pricing. Essentially, this has been done mainly in public employee health plans. And essentially what happens here is the purchaser will essentially say, here's the rate that we're willing to pay you. It's usually a percentage of Medicare. As you can see, Montana and Oregon have done that. We've done that for the public option plan, so Cascade Select, where we've tapped aggregate provider reimbursement at 160% of Medicare. And so we've done it small scale within the exchange just for that subset of standardized plans that are public option plans. Next slide. All payer model. Some of you have heard about Maryland's all payer model, and which is sort of like what we just heard about, the Washington Health Trust, where no matter where the source of somebody's coverage is, the state would establish an all payer model that sets rates for hospitals for inpatient and outpatient services and essentially sets global budgets. Washington had a hospital rate setting back in the 70s and 80s, and our statute was repealed in 1989 for a variety of reasons. Next. Facility fee reform. We know that when hospitals acquire physician practices, they will sometimes bill those services as outpatient hospital services and charge an additional facility fee for the care that's received in those hospital-owned settings. Very few other states have addressed it. The U.S. House of Representatives actually passed a bill on Monday, a transparency bill that has a couple of elements related to facility fees in the Medicare program. Right now in Washington state, if a clinic is charging a facility fee, they have to disclose that the clinic is doing so, but the patient can still be charged that separate fee, and that adds to consumers' out-of-pocket expenses. Next. Medical loss ratio requirements. Many of you know that the Affordable Care Act basically capped the percentage of premium that insurance companies could spend on administration. We use the standards that were set in the Affordable Care Act. Massachusetts is a state that adopted a higher medical loss ratio. Next. And public option plans. We know Washington state, first state to implement public option. Since then, Colorado has established a public option plan. Nevada is in the process of implementing. And I think many of you or some of you have probably seen the Health Benefit Exchanges report that it submitted to the legislature on December 1 that looked at some considerations or options to try to make the public option plan more affordable. Next. State exchange subsidies, we know we do that. Our legislature directly makes coverage more affordable for individuals by enhancing the federal subsidies. does it for folks below 250% of poverty who enroll in the standardized silver or gold plans on the exchange. And of course, now we have dedicated funding for certain immigrant groups. Prescription drug pricing, Washington State just implemented our Prescription Drug Affordability Board that will have the authority over a course of several years to essentially set upper payment limits on what can be paid for some of the highest cost drugs. And then we also have a transparency program in Washington State that the Healthcare Authority administers and reports out on. All of the data that's reported out in that plan is in the aggregate. So while it gives us good information about what's happening across prescription drug spending, it is not able to identify particular, for example, pharmacy benefit managers or payers. Next slide. Individual mandate. Individual mandate was actually in our 1993 Health Services Act. 5 states have enacted individual mandates. And the idea, again, is to make sure that people are participating in health insurance coverage. Next. And so essentially next steps, we've already had some discussions with key stakeholders and we're talking to legislators, because the most important thing is that we have some funding to essentially ask actuaries to do a deep actuarial and economic analysis on a subset of the policy options that are included in this report, with findings due in a final report in August of 2024. And as I indicated earlier, 2 of the policy options also sort of up for consideration are greater oversight of merger and acquisition activity, and then also prohibiting certain anti-competitive contract clauses in contracts between health insurers and providers. So that's where we are.
Wow.
That was like a speed class.
No, it's a ton of information, but great. And we have the full report and the slides in our book, so people can go back and look at it. There's a couple people who had to leave and said that they will watch and look through, and we might have some follow-up questions for you, Jane. But,
Happy
wow.
to do that.
Yeah. So is there, this was too late for any kind of agency request legislation, or it's too early in the thought process to really ask the legislature to do anything?
Well, so the interesting thing is a number of the options that are in this report are likely going to be, were proposed as legislation in 2023. So technically there could be back in 2025. So
like
we have 1508, the healthcare cost transparency bill. 5393 is the insurer provider contracting bill. 5241 is Senator Randall's merger and acquisition oversight bill. There was pharmacy benefit manager legislation that was introduced last session by Senator Cooter. Our understanding is work is ongoing on that bill. So one of the factors that we're taking into consideration in which options we do the modeling will be if any of these pass the legislature or not. But the issue is very much alive in the upcoming session.
Thank you. Any other questions for Jane? Sorry for jumping ahead. Joan, did you have a question or comment?
No, just this work has been so foundational and crosses over into so many of the different initiatives that folks across the state are working on and that the legislature is interested in. That it's been a really interesting read and interesting to partner on. So appreciate it.
Yeah, thank you. And if those bills, any of them pass, that will impact kind of what we're doing too. So appreciate that connection. Yeah. Thank you for doing double duty, being a commissioner and a presenter today, Jane.
Happy to do that.
And traveling. All right, so thank you everybody for sticking around. Thanks to the commissioners who were able to participate. The recording and summary will be posted shortly on the Healthcare Authority website. Again, want to thank our presenters. Our next commission meeting is on February 2 p.m. And as a reminder, our meetings in 2024 are extended, so we'll be meeting from 2 to 5. We have enough content we can get done early too. So look forward to seeing you all at the next meeting. Have a great evening, and whatever the holidays you celebrate, I hope you have a happy one and enjoy whatever your traditions are, like the ones we talked about today. Take care, everybody.